restrictive reversible pattern, the parameters will revert to the previous grade if you do the Valsalva, yes, in vasodilatation, etc. Whereas in irreversible, there will be absolutely no change.
As far as anesthetists are concerned, when there is diastolic dysfunction, what we can do is to prevent tachycardia during intubation, skin incision. We also need to prevent hypercarbia, and we have to try to maintain sinus rhythm and treat any acute atrial fibrillation, avoid any hypertension, maintain good filling pressure unless the patient is in heart failure. So maintain good filling pressures unless patient is in heart failure. Anesthetic drug-induced vasodilatation is very poorly tolerated due to the hypovolemia. And we have to avoid high concentrations of inhalation agents in patients with diastolic dysfunction. And intraoperatively, we have to give adequate myocardial preservation for the hypertrophic left ventricle. And while coming off, think of lusitropic drugs like milrinone, dobutamine, and levosimendan. And always AV sequential pacing is useful in these patients, and maintain adequate PR interval. However, avoid more than 200 milliseconds of PR interval. So AV sequential pacing, when if pacing is needed, use AV sequential pacing. And in the post-operative period, you suspect diastolic dysfunction if there is a requirement for too much of non-invasive ventilation, or if there is difficulty in weaning from the ventilator, then you suspect that there is diastolic dysfunction. That may be one cause for difficulty in weaning from ventilator.
Right. So very important points were mentioned about the maintaining the heart rate, afterload, maintaining the atrial contraction, contribution to the of lusiotropic drugs, AV sequential pacing.
Yeah.
All
And
these very important.
Yeah, and post-op in the perioperative period, you avoid hypovolemia, tachycardia, and arrhythmias. If they occur, you have to treat.
Treat aggressively. Yes.
Yeah, and
elective non-invasive ventilation also may help in the post-operative. Usually they will have increased airway pressure, so they will have signs of increased airway pressure on chest X-ray. We can identify the curly lines. And if these patients have increased signs of increased airway pressure, then probably non-invasive ventilation electively may be.
Anybody from the audience wants to say something, please feel free. Anybody from the group who have joined? Any comment, questions? Next 10 minutes.
whenever we assess diastolic function, we must also remember to assess the LV filling pressures. And we need to remember that LV diastolic dysfunction may be present despite normal systolic function. It is good that the latest AHA guidelines have simplified approach towards detection of diastolic dysfunction.
That is true.
Good morning, sir.
Yes.
Yeah, sir, I am Dr. Bhargav. I wanted to ask, like, I've been evaluating this. If we do a pre-op echo, transthoracic itself, and see the E by E prime ratio, that is an estimate of PCWP or LV filling pressure. Simplified formula is E by E prime plus 4. So does it really correlate well? Because it's quite variable. Whenever we put a PA catheter, when we do a transthoracic echo and then put a PA catheter,
yes,
the relation between E by E prime plus 4, or a simplified formula for estimating the LV filling pressure, versus the PCWP that is assessed by the Swan-Ganz. Sometimes it matches well, sometimes it doesn't match well. Sir, your comment, please. What do you think about this? Preoperatively, can we guess what would be the, like, how reliable is this? Thank you.
I will just respond to that, and also then I'll ask Rupa and Srinivas to pitch in. See, E by E prime as a marker of the filling pressure is validated, and I think it works. To my mind, it works. And that is one of the parameters which is taken by the as one of the criteria to assess the diastolic function in the guideline. So I think it's a valuable parameter, and in a patient with diastolic dysfunction, it will correspond to the pulmonary artery wedge pressure. So Rupa Srinivas.
The minimum, I mean, a few cases that I have seen, I realized that in grade 1 and grade 2, like that is restrictive and the grade 1 pseudo normal,
Yes.
those grades it matches well. But in patients almost without any diastolic dysfunction and the severe forms, I don't seem to, I mean, it doesn't match very well. That's what, even the literature, I didn't find any things written. So since you're saying, I'll just evaluate again.
My take is that it's a valid parameter.
I'm in the lobby, but are you able to hear me? No, no.
Let us see what Rupa has to say. Rupa and Srinivas.
Hello. So the E prime usually under anesthesia because of the effect of inhalation anesthetic agents and because of other the perioperative factors, it may or may not be same as what we get with the transthoracic echo in the preoperative.
Yeah, I'm able to.
So as you mentioned that it is only if the patient has got LV diastolic dysfunction, when the LA pressure is significantly raised, then only probably it will correlate with the PCWP. Otherwise, the LA pressure is low. It may or may not correlate with the.
Now, can you see me?
But I have seen come across a couple of studies where they found a good correlation between these two when the diastolic dysfunction is say moderate, like say normal pattern. But if the diastolic function is normal, it may or may not correlate. That kind of study I haven't seen comparing between the normal function and a patient with severe restriction or with a diastolic pseudo-normal pattern. So,
Rupa, any comments on the side?
In patients, even in patients with normal LV ejection fraction, average E by E prime more than 14, then septal E prime velocity less than 7 centimeter per second, or lateral E prime velocity less than 10 centimeter per second, then you think of diastolic dysfunction.
That is true.
Also, you have to look at the.
The question is, does E by E prime correspond to the left atrial pressure or the pulmonary artery bed pressure measured by Swan gun? That is the question. Will it correspond? To my mind, my answer will be affirmative. Yes, it will correspond. But I would like you to comment on.
It should, but I'm not so sure.
Sir, the idea behind asking this question is, sorry, shall I ask? I'll just take a second. Sir, the idea behind asking this question is, in case I am able to predict, like most patients, even if they have reasonable LV systolic function, they seem to have a bad diastolic function. So in that situation, I am a little, careful. Of course, I have to be careful all the time while inducing and intubating any cardiac case. But in these situations, I can expect that there will be more hemodynamic variations. That's the idea of assessing preoperatively before induction of anesthesia. So that is why I wanted to know whether, of course, it changes with anesthetic medication.
Are you talking?
I have minimized. Are you?
One gas induction and checking the pulmonary artery occlusion pressure, comparing with the TT findings. Is that what?
Okay. So I will
yes, sir.
remove the minimized thing and make it full screen. Okay.
TT value from OPD.
Yeah. Okay. Full screen.
is the value of E by E prime determined from TT from the outpatient department, or you are doing it on table?
It's on table, sir.
On table.
Just before induction, what I do, when someone is putting the radial line or something, if I do a transthoracic echo and get a E by E prime,
okay,
so that I can have an estimate of what is the diastolic dysfunction. So
yes.
because I realize that people with these kind of hidden diastolic dysfunction
Yes.
are hemodynamically unstable, although seemingly they are having a good LV function or a reasonable
Yes.
LV function. So these are the patients who turn unstable. So probably we can be more careful with these. That is the idea of doing a just before induction transthoracic echo.
So,
I'm really happy that you are doing this, and I really appreciate that you're doing this before induction and estimating the E by E prime and checking whether it's corresponding. That's really good. Uh, if you can do more cases and get a meaningful data, that will benefit most of us.
Certainly, certainly, sir. I'll report that. Thank you.
Yes, yes. Sanjeevini, are you ready?
Yes, yes. So extremely sorry, Dr. Murlidhar. I did never wanted to happen this.
Don't worry.
I
We have
probably
26 minutes. We
okay.
have 6 minutes because we want to finish by 10 o'clock.
Okay, okay. I will just yeah. Should I start?
Yes, please.
Are you able to see my
Yes,
screen?
able to see.
Okay. So I didn't listen to your conversation. Couldn't listen to your conversation. I don't know how far you have. I mean I would have loved to listen to, but really this topic is that it takes considerable knowledge just to realize the extent of our ignorance. It's said by Thomas Sowell, and it is just even today it is a blind man and elephant situation, and we are struggling to reach to a proper solution before surgery, diagnosis and management, and uh, doing proper management during surgery and post-op. So diastolic failure certainly is a big problem of this century. It was there, but we were not able to find it. It is an iceberg of heart failure problems. Incidence is more than 50% of all heart failure patients. Mortality and morbidity is at par with heart failure with reduced ejection fraction, that is known as HEP-REF. That is equivalent to, ultimately it goes into systolic heart failure. It is now recognized as an independent predictor of adverse cardiovascular event, that is MACE, major cardiovascular events. And for that, all vulnerable patients with dyspnea or heart failure should be evaluated for diastolic dysfunction. So I'll be dealing this topic under this heading and we'll just proceed one by one. That is Introduction to Diastology. This is popularly known as HEP, that is heart failure with preserved ejection fraction. So we will be seeing few ventricular diastolic tracing and its components. We'll go through sucker and pusher effects. One has to understand this physiology so that management becomes very easy. And we will see certain laws of cardiology with respect to systolic and diastolic dysfunction. So you all know this diagram since first MBBS, and these are the tracing of pressure tracing of LV and LA, how it correlates with E and A of mitral valve flow profile. So starting with this simultaneous pressure tracing of LV and LA in diastole. So this is LV relaxation, initial LV relaxation, followed by there is sharp initial dip, that is sucking action. That LAP is, LV pressure falls just below LA pressure. Then this is the slope of diastasis. Okay, this is the slope of diastasis, and LV stiffness and compliance determine this slope. And this is end diastolic, LV end diastolic pressure. Again, LV stiffness and compliance determine how much is LVEDP. So early diastolic gradient between LA and LV, which happen due to sucking action as well as little pushing effect of LA, normally is is responsible for E wave on echocardiography. So what is the definition of LV diastolic dysfunction? This is very important because we have to all the time differentiate between systolic dysfunction and diastolic dysfunction. So elevated LVEDP with normal EF and normal LV volume, because you know that in systolic heart failure there is increased in LA volume, but here the LV volume is normal and that equates with diastolic dysfunction. So this is the early relaxation. And what do we measure at tissue level? This is a tissue characteristic, isn't it? So we measure by tissue Doppler E prime. That is the concept one has to understand, that we are measuring tissue velocity at septum as well as at the lateral wall of mitral annulus, and it is causing E prime and A prime. And normally E prime is obviously more than A prime. Now coming to blood velocity. Now we have measured tissue velocity. Now coming to blood velocity, this is known as E wave, blood flowing from LA to LV, and usually it is due to sucking effect normally. And this is E wave, and then atrial kick is A wave, and usually the EA ratio is more than 1 and less than 2. When there is tremendous rise in LAP due to various pathological situations like hypertension, aortic stenosis, and there are many situations causing this effect. There is E is more than A, more than 2. I just wanted to show you how pushing effect is more important over here, because LV is already hypertrophied. LVEDP as well as during the diastasis also LV pressure is very high, and there is a steep A because of severely hypertrophied ventricle. LA has to push all the blood in the early phase only. So E is tall and there is hardly any blood in the left atrium. So A is very small, and besides that, atria is not able to push later on against the high raised LVEDP. So this is decompensated diastolic heart failure or dysfunction, and mainly pusher effect is applying over here. So coming to this golden ratio in diastology, that is E by E prime. So E wave, we saw that it is the blood flow from LA to LV, which is causing E wave at the tip of the mitral valve. It is a function of LA pressure, we saw that, and it is also a function of LA relaxation, initial LA relaxation. But E prime, which is a tissue velocity, that is function of only LV relaxation. So if we divide this, what remains is LA pressure, and that is the crux of the matter, and that is the most important parameter one should know during diastology. So E by E prime, when it is 14, it is raised LAP. So let me walk you through all these different grades. You all know this, but I just wanted to revisit it because it is an important topic and it is very commonly seen. We'll study this in terms of impaired relaxation. Normally it is there is no impaired relaxation, and all these three grades, yes, there is impaired relaxation, which is shown by green arrow in normal and now black arrow showing impaired relaxation. Coming to increase LV stiffness, there is normal LV stiffness in normal patient. In grade 1, it is plus or normal. Then grade 2, 2 plus, and severely stiff ventricle in grade 3, which is shown in this green arrow is normal, yellow is little abnormal, and red is severely abnormal, LVEDP, due to tremendous increase in LV stiffness. Coming to LA pressure, again, because LV stiffness is increasing, LA pressure goes hand in hand with that, and so in grade 2 it is 2 plus, and grade 4 it is 4 plus. It is shown here by this green arrow again, and this pinkish arrow showing increased LAP. Why one has to know this? Because management during surgery, pre-operative and post-operative certainly changes with these parameters. So initially it is a sucking effect, then is the pusher effect, and that is how this is compensated diastolic dysfunction, normal LAP or PCWP at rest. But mind well, these patients do complain of breathlessness. So there is raised LAP and EA ratio during exercise or tachycardia, which is a common situation during surgery. So these grade 1 are likely to be pushed to grade 2 or grade 3. That is why we have to study this in detail. I will just go fast through this. You all know this and how you see E wave is initially reduced and then LAP increases and then E wave goes up, A wave goes down. Similarly, pulmonary vein pattern, S wave goes down. And tissue velocity, again the same pattern. This I will skip and I will come to that later on. So what is the sequelae of all this? Sequelae of chronically raised LA pressure is LA volume increasing, pulmonary hypertension is more, ultimately back pressure causing RV diastolic volume overload and TR velocity is increased, and that is why it is taken into the guidelines. Let us see few laws. I just want you to go through this so that otherwise it is a confusing topic. So it will make you understand little better. So this is Frank Starling's law, famous, we know that. And in systolic heart failure, it is cardiac output against LVEDV. This is volume. See, by looking at this, you know that there is reduction in cardiac output in systolic heart failure, but it is also a flattish curve. What does that mean? That you can, it can tolerate volume to a great extent, or even volume reductions. By that I mean diuresis can be tolerated for a considerable time, as against the diastolic heart failure. Again, systolic heart failure is very sensitive to afterload. This is stroke volume against afterload. Whenever there is reduction in afterload, for a long time, the stroke volume is maintained. So, in short, failing heart is very good. It likes reduction in afterload. Its mechanism, its contractility is improved when we give afterload. We have been treating these systolic heart failures initially with sonide. So coming to that systolic heart failure can tolerate afterload reduction very well, as against severe afterload reduction cannot be tolerated by diastolic heart failure. So we will just recap systolic heart failure. There is why we have to combine, I mean all the time compare and contrast, because many times patients do have both and we have to know which is dominant. So systolic heart failure is impaired contractility, low stroke volume, obviously. There is progressive LV dilatation causing more afterload, and that is why we give afterload reduction in these patients. These are more afterload dependent. I just told you that if you reduce afterload, they behave very nicely. And this systolic heart failure, relatively easy to treat, that they tolerate both pre and afterload reduction. As against diastolic heart failure, there is slow LV relaxation. And I will just show you in the next slide that there is a steep LV pressure volume curve because of increased LV stiffness. It is more preload dependent as against to LV systolic failure. But in this afterload reduction and preload reduction, there is a very narrow therapeutic window. That is what one has to understand, and that is the crux of the point where management changes. So this is the pressure volume relationship comparing systolic heart failure versus diastolic heart failure. This is pressure, LV at diastolic pressure and LV at diastolic volume. This is the normal heart. Look at this, systolic heart function can tolerate it for a long time because it's a flattish curve, but diastolic dysfunction certainly cannot tolerate anything which is with volume. So preload reduction is, I mean, considerable preload reduction is not tolerated by diastolic heart failure. So one has to ignore if PCWP is little high, not very high, but little 15 to 18 at normal LV volume, because we know that this diastolic heart failure, they do have normal LV volume. This is very important. Ignore this little high PCWP. Don't try to reduce it vigorously to maintain normal cardiac output. So how do one manage if we are not able to give diuretic? How one would manage and bring this patient to normal? Give mild lucitropic drug. Mild afterload. Mild word is important. Change the curve from 3 to 1. So this concept is also very important. I think you discussed, Dr. Muralidhar discussed this in this forum previously. I could hear it a little bit. So this is grade 1. There is small e because there is stiffness of ventricle has started, impaired early filling, and large a. Because there is small e, LA has to contract vigorously to push the blood, and this is the flow profile. So if tachycardia occurs at this stage, you can give little beta blocker or any other agent to slow the heart because there is adequate blood still remaining in LA to push it further, and because of reduction in the increase in the diastolic rate, diastology, increase in diastolic time, heart will be able to pour more blood during E. Okay, so one can give small dose of beta blocker in grade 1 diastolic dysfunction. As against that, if this is the situation, this is decompensated grade 3 with L wave and a raised LAP and all that. This is narrow E wave due to quick LA LV pressure equalization because they are all are both are high. Atrial kick cannot push much against high LV diastolic pressure, and almost all blood is thrown into ventricle because of raised LAP initially only. So if this patient is in tachycardia during surgery, don't try to correct it vigorously because that is not going to serve any purpose of throwing blood into ventricle because already everything is gone inside. Hardly anything is remaining in the LA. That is number one. And number two, this little bit of tachycardia up to 120 is required to maintain cardiac output. So this is the important concept. So what do you do? Give mild diuresis and afterload reduction. That is the only thing one can do. So this is systolic heart failure heart with big volume, and this is diastolic failure heart, big hypertrophy and very less LV volume. Let me show you. Are you able to see video? Dr. Muralidhar?
Yes, yes, we can.
Yes.
So this is systolic failure. I'll just rapidly run through this. We all know this. This is systolic failure, and this is diastolic failure. Look at the heart, and in Sachs view and in transesophageal echocardiography. So coming to echocardiography, this is the normal diastolic function. E by A is more than 1. Then this is grade 1 where E is less than A by more than 0.8. Then this is grade 3, E by A more than 2. I'm just going through fast. And this is the tissue Doppler where E is more than A in normal patient. And this is the patient with tall E and very small E prime. So the ratio is 26 by 1, very high LAP, suggesting very high LAP. So coming to clinical presentation, my friends, it is very, very non-specific. Dyspnea on exertion, pulmonary congestion, to acute pulmonary edema, it's a range, pedal edema, fatigue because of right heart problem. So it's a very difficult to diagnose just on based on symptoms. So let us, this is very important concept that do Doppler patterns match with the patient symptoms. So this is the grade 1 or grade 2, that is pseudo-normal, where patient gets dyspnea only after exertion. So you have to ask this in the preoperative period. And when patient is having dyspnea at rest, usually it is grade 2 or grade 3. these are various causes. I'll just rush through. Most common is hypertension. And another important thing is ask patient about sleep apnea. Patient may not have any hypertrophy. Even then, these patients with sleep apnea syndrome, they do have severe diastolic dysfunction. Another important thing which is worrying all of us nowadays, that it has come to a very young population. Many in 30s and 40s, they are having diastolic dysfunction. So I don't know what will happen to them with when they grow. So now let us see, you all know this. I'm not going to go through this. This is when there is any problem with left ventricle, or already there is hypertension and ischemic heart disease. This chart is used, but this is complicated, as told by many people that it is complicated, and that is why there is LS trend coming up, which I will just go through rapidly. So I'll just show you few echo reports. You know, these are all real reports which I had come across. See, this fellow has written severe LV systolic function, LVF 30, and no diastolic dysfunction. This cannot be. It has to be there. Whenever there is severe diastolic dysfunction, there has to be some diastolic dysfunction. Then what do? Ask cardiologist which is dominant. The same patient when I did, I am not boasting of course, but I found E by E prime more than 14. So obviously he was in grade 3 with raised LAP. This is another patient, very nicely written over here, that grade 2 diastolic dysfunction with raised LAP. Now see this report. This is 49 years with LVH with pulmonary hypertension. Read this: severe tricuspid regurgitation, severe pulmonary hypertension, mildly dilated right heart. So it has come up to that level also. There is LVH, but there is no mention of diastolic dysfunction. This is not on. One has to, you have to ask them pre-operatively how much is the grading, how severe is the diastolic dysfunction. This is another man with E by E prime more than 14. So coming to the funny part of this diastology. See, this is the beautiful graph I saw, that at a normal young healthy individual also there is very tall E, small a, and in severe grade 3 diastolic dysfunction also there is severe very tall E and E by A more than 2. Again, S and D ratio is also sometimes in normal patient S is less than D and S is less than D in pulmonary vein in severe patients. So how do you differentiate? This is the typical U-shaped distribution. So how do you differentiate? So tissue Doppler helps us, and athlete's heart, normal individual, put tissue Doppler. If it is normal, they are normal. Don't label them as diastolic dysfunction patient. That is what I wanted to imbibe upon you. And this is the patient, normal, healthy, young adult patient. See, E by A more than 2, but there is no TR. The tissue velocities are normal. Look at this pulmonary vein. I have taken pulmonary vein from short axis. These are transthoracic images, of course. This is studied well in transthoracic only. And whenever you take pulmonary veins at two different sites, the sensitivity increase. So both the pulmonary veins showed S less than D. This is the pulmonary vein. And then one would, if you don't take proper clinical history, one is inclined to say that this is a diastolic dysfunction, which is absolutely is a normal, healthy young adult. This is elderly hypertensive pseudo-normal patient. I took his velocity. It was looking as normal as that. I asked him to do Valsalva and see how beautifully he has shifted to grade 1. So this is grade 2 pulmonary vein also, but pulmonary veins are normal, so normal LAP, and he is on ACE inhibitor and mild diuresis. So naturally, many times there is a mixed picture that E by E prime is normal or LA volume is normal. This is an old lady with severe LVH, again grade 1 DD, severe hypertrophy of the ventricle, and just wanted to show you a few cases. The same lady with pulmonary vein also normal, and another view of this mitral profile, and there is mild reduction in tissue velocity. But here again, you can't really say that there is raised LAP. Another important thing, see, we have many HOCM patients, but this is the first time, few months back, I saw this young IT girl with severe HOCM. See the hypertrophy of the heart. See the SAM as well as metal regurg. This is the SAM beautifully shown over here. And this is SAM seen in Sachs view also. How this AMN is touching the septum. Her diastolic dysfunction was, LA volume was normal. There was no TR. So ideally she fits into indeterminate type of, we cannot decide. She is very young, so probably she will go into different grades, but right now she is okay. Only thing is that there is reduction in the tissue velocity. She will probably go, she will have to follow her very well. Another HOCM with this is a LVOT gradient, this is E and A. What I wanted to tell you over here that S and D are many times normal in these patients because of vigorous LV, compensated vigorous LV contraction. But A duration of mitral, MA, and A duration of pulmonary vein, there is difference. So if you calculate this and if it is more than 30, there is increased LVEDP. So this is not very reliable, but AMV and A reverse APV difference is more important. Another case with tremendously reduced E prime. Another case with the same finding. And this is how where TR velocity is shown, and it is certainly more than 2.8 to label it as a diastolic dysfunction with raised LAP. This is one patient with severe aortic stenosis, again grade 1 DD. And this is showing reversal of S and D ratio with raised LAP. So experience and modernity, they should go hand in hand. And this is where comes the value of LS strain. Deepak and Shreedhar, they had beautifully taken lecture on this. And this is by Thomas Lisa. And she says that, and it is known worldwide that LS strain starts affecting very early as against LA volume. So LA volume is given less importance now, and LS strain is getting more and more popularity. And this is the single parameter which would tell you that left ventricular feeling pressure is high. We are confused over here whether to label them high LAP or not. But only one parameter would certainly give you whether patient is having high LV feeling pressure, because that is the only thing which is going to change our management of this patient. J.O., who has developed many guidelines, he has come up with this simple algorithm to again, modify or make it simplified to label it in different grades. This is again showing LA reservoir strain. See, LVADP is less over here and there is good LA strain. LVADP is more 19 and LA strain is reduced. Again, the same thing, LVADP is 5 and LA strain is good. So it is a single parameter, but it takes time to learn this, and of course vendor availability and many things are there. But it will, I'm sure that many young people will come with their LS strain values report in their hand now. So, but what happens during intraoperative period? It is difficult to assess changing loading condition, changing systolic and diastolic function, dynamic hemodynamic state, heart rate, loading condition, and all those things. And preload affects pulmonary systolic flow also and LAP also. So even SD and all other things are very difficult to assess. So one has to know it before on transthoracic echo, very detailed analysis of diastology. So coming to pre-operative management, unlike systolic failure, diastolic heart failure has no specific treatment. Aim is to treat underlying cause. Afterload reduction will improve relaxation and cardiac output. These are oral tablets. Reduce congestion with mild diuretics, and if in A, of course, you have to control rate and rhythm, but you have to remember that therapeutic window is very narrow. So general principles during operation, systolic heart failure always has some diastolic dysfunction. Establish the dominance before. Adequate sedation and optimum analgesia. Avoid vasoconstriction. Prevent rise in afterload. Adequate depth of anesthesia and warm fluids. And adequate PEEP. I mean, PEEP, if more, can increase the afterload. Again, as far as preload is concerned, I have already told you that there has to be judicious increase in preload whenever there is grade 1 DD with normal LAP. Do watch SpO2, it's an indirect surrogate sign of rising LAP, provided there is no other reason for drop in SpO2. Grade 3, raise LAP, reduce preload with mild diuresis. Severe diuresis is harmful. Intraoperative management, as far as afterload is concerned, mild afterload reduction, lucitropic effect if BP is raised. I think Sreenivas has done a study on this, that isoflurane is a little better than sevoflurane. Inodilator, dobutamine and milrinone if required. And severe afterload reduction is harmful. As far as heart rate is concerned, I have explained you how beta blockers can be given in grade 1, compensated, but no beta blockers in grade 3. Tachycardia is required to maintain cardiac output, except heart rate up to 120. And rhythm and rate control if atrial fibrillation is there. So diastolic dysfunction is an important consideration during perioperative period. Echo provides a snapshot of DD to guide management, and narrow therapeutic window renders DD treatment challenging. Thank you, Dr. Muralidhar, for this, and really nostalgic for these moments. And thank you very much. And I'm very sorry for the technical glitch.
Thank you, Dr. Sanjeev. That was an excellent presentation of overview of diastolic dysfunction. And what I appreciated is that you mentioned about the U-shaped curve, influence of age on the most of the parameters which we look at. And also you have taken cases from your own series and illustrated them. And also you mentioned about LA strain, very important upcoming subject. Thank you so much. Before I ask question, I request Rupa and Srinivas to give their comments.
I'm not able to hear Rupa. Are you able to hear Rupa?
Rupa,
About some specific situations.
Mute yourself.
Am I audible?
Yes, yes.
Yeah, in specific situations such as aortic stenosis and regurgitation. In aortic stenosis, the tissue Doppler imaging cannot be used because there can be calcification, mitral annular calcification. In severe aortic regurgitation, due to premature closure of mitral valve and diastolic MR, transmitral velocities, they may not be useful. And so in this case, you just look for a LI enlargement, an average E by E prime ratio more than 14, measure the TR jet velocity, and there will be elevated LV filling pressures. So in specific situations, even in mitral regurgitation, E by E prime can be used because E is raised, LA size is increased, TR jet is not reliable in mitral regurgitation. In that pulmonary, that AR to A duration can be useful, pulmonary. And actually, there are no guidelines to evaluate diastolic function after mitral valve replacement or mitral valve repair.
Yes. Actually, Dr. Muralidhar, are you able to hear me?
Yes, we are.
See, this special situation and diastology is another big topic, and I think we would sometimes because MAC is there, then so many things are there that makes it, atrial, even in atrial fibrillation, it's a problem.
Yes.
So that is a different topic, and I'm very privileged to have Rupa as a guide. I couldn't talk to her before lecture, and I really thank you for that.
Srinivas?
Madam, very nicely presented. I think you described especially the heart failure aspect very well. So only one query I have. At one place you mentioned that so you have to mute
Class.
you have to mute because it's
I'm not able to.
yeah.
There is a background noise is coming on.
The heart rate 120.
Heart rate 120.
Yeah.
Up to 120. You can't reduce because cardiac output would suffer. That's what you wanted to ask? No, I'm not able to hear you, Srinivas.
No, the background noise was heart rate of 120.
Okay. Okay.
Hello, sir.
Yes,
Can I ask one question, sir?
Yes, you can.
Sir, for a patient with hypertensive, 70 years old patient, who is having diastolic dysfunction also, coming for a non-cardiac surgery, for example, incisional hernia or inguinal hernia repair, whether regional can be tried or contraindicated?
Very nice question.
Very nice question.
What's your name, doctor?
Dr. Hemodynamics, sir, your student.
Okay. Great.
From Pondicherry, sir.
Yes. You want to reply to that, and then I will, if needed, I'll give my response. If needed. Regional anesthesia in a patient with diastolic dysfunction.
Rupa.
Question.
Rupa, Murlidhar sir has asked you to.
I think
Sanjeevini, both of sorry.
I think it should be advocated.
Right.
Yeah.
Sanjeevini?
Yes, it depends on how much is the grading of diastolic dysfunction. Again, preoperative analysis is very important. Sometimes, if you give spinal, it is uncontrolled afterload reduction. See that it doesn't come up. You have to give very, area specific blockade is essential. If you can't do that, then better to go for general anesthesia because it is a controlled situation. But yes, if you are able to handle regional, yes, go ahead. No problem.
Thank you, ma'am.
In patients
Thank
with
you.
diastolic dysfunction, preoperative treatment of heart failure is very important. Using diuretics, AC inhibitors, ARBs, beta blockers, treatment of hypertension, diabetes, and also dealing with obstructive sleep apnea. If necessary, AICD insertion, all these are very important. And we need to assess the functional capacity. Less than 4 meds is increased risk. Look at the electrolytes and see the X-ray. Look for pleural effusion, alveolar edema. All these are important in patients with diastolic dysfunction. About post-op, we already talked. We talked about the post-op conditions in the beginning.
Dr.
Bhargava, Dr. Shreedhar speaking.
Yeah, Srinivas, tell us.
Madam, you mentioned that patient may develop RV diastolic volume overload.
Yes.
If there is a severe increase in the diastolic pressure, one of your slides showed that there is a RV diastolic.
Yes.
How why RV in diastolic volume overload should occur?
Ultimately, because of severe TR, ultimately RV starts dilating and failing. That is the ultimate sequelae of all these.
So basically, it is a pressure overload or the volume overload that will predominate?
No pressure.
Because pulmonary hypertension, you said pulmonary hypertension.
Yes. Pulmonary hypertension. So of course there is pressure overload. Of course, it's like mitral stenosis, isn't it? ultimately LAP rising and then causing back pressure, and it's the same phenomena. But here LA rise is due to some other reason, like there is no mitral stenosis, but the LVEDP is increased. That is causing back pressure.
One more comment, madam, about the perioperative period.
Okay.
We should maintain adequate AV interval when you are going for AV sequential spacing.
Yes.
We'll have to titrate with the echocardiography. We can actually titrate the filling period of the LV.
Yes.
So that should be
Very
optimum.
true. Yes, very true.
Dr. Bhargava, are you available?
Yes, sir. Yes.
Dr. Bhargava had one important observation. He said that the pulmonary artery occlusion pressure versus E by E prime ratio are not tallying with each other just before anesthesia. Sanjeevini, do you have any comment on this?
I didn't listen to this, whatever he said.
If I understood
but
rightly.
what did he say? He said preoperatively he does by putting Swan-Ganz pulmonary occlusion pressure and E by E prime, right?
Yeah.
And they are not matching.
He does.
See, I will tell
They're
you.
They're not correlated.
Yeah. See, this PCWP, that is what we call pulmonary occlusion pressure, is little less than LVEDP. Okay, and PCWP is a function of diastasis. And in E by E prime, we take even LVEDP also comes into play. So it will never match. It's a very good observation. You should do research on this, because always PCWP is 12 and filling pressure is around 13, 14. It's a few millimeters difference, millimeters of mercury, but it is there.
Ma'am, can you just repeat it once again? I'm Dr. Bhargav, ma'am.
Okay, see, LAP, PCWP is a function of diastasis. During diastasis, there is no flow at all. We measure the pressure when there is no flow at all. But in E by E prime, we are taking into consideration LVEDP also, with the textual velocity, no? So it will never match. PCWP is little less than LVEDP. That is the concept.
No, he also said that the E by E prime plus 4 is equal to LAP.
That is written in one of the textbooks.
When they say LAP, see, this is further ramification of all this pressure.
That is my point. There will be a good, excellent correlation with E by E prime and the left atrial pressure. The correlation will be maintained. It will not be exactly same.
But I think the trending is important. Whatever is the difference, if during surgery that difference changes, then obviously your LVDP is more, and PCWP is also.
More cases than get
yeah, he should do. This is a very good topic. I just loved that point.
Very interesting.
Yes.
And if it is proved that what he said is right, that's important information.
Then maybe he will come up with beautiful finding.
Madam, can I make a comment in this?
Yeah, you can.
Madam, what I understand, when the mean LA pressure is increased, that is only when there is pseudonormal, that is a grade 2 or grade 3 diastolic dysfunction.
Right.
When the mean LA pressure is increased, then there may be a good correlation. As you mentioned, the values may not be exactly same, but if you see the Pearson correlation, there is a good correlation between the mean LA pressure and the PCWP. But when the LAP is low, itself is low, then this correlation may not be there, because I have come across 2 studies in which they found a correlation of almost 60 to 70. So PCWP may or may not be equal to the mean LA pressure in all cases. It is only when the pressure is elevated, then the pressure will be more or less uniform throughout in the ALA. On the phase of cardiac cycle. As you mentioned, it's mainly the function of the diastasis
Yes.
That is mainly when the LA pressure is low. So when the LA pressure is
normal,
raised, there may be better correlation between the E upon E prime with the swan gas.
But in which cases he had done? He had done in diastolic dysfunction or normal cases?
No. Patients are coming
Pre-op.
to surgery on the table. CT is done and swan gans is
No,
floated.
but what was the approximate grading of diastolic dysfunction in that patient?
Ma'am,
I mean,
yes, ma'am. So, very few patients that I've done, what I've realized is, like sir said, grade 1 and normal, grade 1 dysfunction, it's actually very difficult. The E by E prime doesn't match very well. But as the grade increases, it matches well.
that
You can
is what
actually,
Dr. Sree was told just
yes,
now.
yes, yes.
Yeah,
This is
very
what I'm
precise.
saying. So it is not matching across the spectrum of diastolic dysfunction. In higher,
So
it
you
is
can
matching.
use the word correlating. It will not
Probably
match.
match, yes. So we cannot estimate, but we can have only a. So this is what I found.
But I think
And also,
even if they don't correlate, again trending is important because during surgery everything is haywire. So anyway, we are not able to exactly diagnose, but see the trending. If patient is deteriorating or improving with the help
and
of
also I would like to
pulmonary
comment that
veins and anything. E
yes,
by
yes.
prime.
I also would like to comment that the swan gans floating is it done after induction or before induction?
Yes,
You have
that is
done
also very important.
after induction, the values may not
Yes,
correlate.
yes.
So the loading conditions are different after anesthesia, so it will not correlate. I'm also saying matching. Sorry, it's correlating. They may not be correlating.
But usually swan gas is put before induction, isn't it? So
We ought to do it after induction. At least I do it
okay,
after.
okay.
Because I'm confident that I don't collapse patients during it. Thank you.
Madam, one more query.
Yes.
Is the LS strength visible in the intraoperative film?
It's
Because we don't see the entire LA wall with the
yes.
transcranial echocardiography.
Yes,
So
yes.
we require transthoracic echocardiography to visualize the LA.
See, they are doing deep transgastric LA strain. Okay, whatever LA is seen, they are doing it. That is what Deepak and Shreedhar told us in the beautiful lecture they took. And the values are different compared to transthoracic and transesophageal. But certainly it's a new era, new arena. But still, trending. If trending we do, we would come to know whether it is increasing or decreasing. I think trending word is very important in during surgery. So deep transgastric and
the difference between a deep transgastric and what you get with the apical fourth chamber with transthoracic. The probe position and the region of interest is away in the transmural echocardiography. This is a far field. So especially the pulmonary veins and the LA appendage are not very clearly visualized because they are in the far field with the transmural echo.
Yes.
While in the transthoracic echo, usually you see the structures more clearly.
Yes.
That is my.
What I remember Shreedhar had told that they have they are doing even LA appendage strain.
Yeah.
And trying to analyze the diastolic dysfunction. So that is a good idea. That is seen very well. So appendage. I don't know if they will
There
keep
is
up.
Dr. Keshavamurthy has raised his hand. Keshav, tell us what do you want to ask?
Morning, madam. Good morning, sir. Srinivas and Rupa, madam. The very nice presentation and very practical. I wanted to add one more practical point to that. We most of half my fellows have already left the meeting, I think. But most of it is you see that our noradrenaline is going as soon as the pressure drops in most of the CABG patients.
Yes.
Which will be in nowhere you may means in the presentation it was that there is increase the afterload. It is all either decrease the afterload or increase the luciotrophic effect of the myocardial contraction. So I want to tell that noradrenaline should be the last choice to start anything unless you have been proved positively that there is severe vasodilatation where you can start a small bit of it. Otherwise, most of the time, grafting patient will be running on 6 to 8 ml of noradrenaline, which may be deleterious after the procedure. That's what I just
I
want.
totally agree with you, and I'm very much for your opinion. And I use noradrenaline only if other things fail.
If you have proved that everything
I
else has
just
not worked, then noradrenaline should come to the picture. But I
yes,
see
yes.
most of the time that is the first drug which is started to
I know. You try to change that. I'm requesting you people try to change it.
normalization of the pressure, blood pressure, and maybe bad effects are happening on the heart side.
And not only that, can I speak Muralidhar on noradrenaline issue?
No, it's out of bounds.
I just wanted to comment because most of those were.
When you use norepinephrine, we are optimizing the afterload. We are not increasing it. And Rupa, you wanted to say something. What is it?
Yeah, that is to Bhargav. If Bhargav is wanting to correlate PCWP with the E by E prime more than 14, then he can also correlate that PCWP with a LA volume index of more than 34 ml per square meter and a TR jet velocity of more than 2.8 meters per second, ARA duration of more than 30 seconds, pulmonary SD ratio less than 1, and deceleration time less than 140 milliseconds. So if you are going to do a study, you might as well correlate with all these things, Bhargav.
I think so. You should consider all the parameters, absolutely. Yeah. Bhargav, are you listening?
Yes.
He is from which institute he is from?
Ma'am, I am in Pune, ma'am. I am in Army Institute of Cardiothoracic Sciences, FMC.
So we are near. So
Yes,
you start
ma'am.
doing
Absolutely.
cases.
Yes.
That's a wonderful topic actually.
He did the diaphragm or this.
Yes, sir. Yes,
Having
Rupa
5
ma'am and
awards
Srinivas sir.
in the IFTAN.
I think it is time to say thank you.
Rupa ma'am, can you please tell the anesthetic consideration one more time, ma'am? Please repeat it, ma'am.
Anesthetic preparation one more time, Dr. Rupa.
Diastolic dysfunction.
Yeah. Intraoperative goals, I'll say, prevent tachycardia during intubation, skin incision, avoid hypercarbia, maintain sinus rhythm, treat any atrial fibrillation, acute atrial fibrillation. Try to avoid hypertension at all times. Maintain good filling pressures unless patient is in failure. And avoid anesthetic drug-induced vasodilatation because this anesthetic drug-induced vasodilatation is very poorly tolerated in these patients. And avoid high concentrations of inhalation agents. And intra-op, see to it that the patient receives adequate myocardial preservation because the LV is hypertrophic. And while coming off, use lusitropic drugs such as milrinone, dobutamine, and levosimendan. And if patient needs pacing, then you go for AV sequential pacing. And it's very important to maintain adequate PR interval. However, avoid more than 200 milliseconds PR interval. And that's all. And in the post-operative period, if the patient is requiring a non-invasive ventilation for too long or there is difficulty in weaning from ventilator, always suspect that there is diastolic dysfunction and treat it.
Thank you, Rupa, for that summary. And I would like to say that usually when I give talk on this matter, and normally I end by saying, dance like Lord Nataraja and sleep like Sri Ranganatha. So it is time to relax. Thank you so much. Relaxation is also very important. Thank you for this talk. And enjoy your Sunday and relax so that tomorrow you have to start working in the operating rooms with full energy and strength. So thank you so much and good luck. And Rajiv will play the Jack video. Rajiv, are you there? If he's there, otherwise we meet you on Sunday. Thank you so much. Lovely talk and so much of discussion went into this. Thank you so much.
Bye, sir. Bye, Sanjeevini madam. Bye, Bhargav.
Thanks for the opportunity, Dr. Muralidhar.
Thank you, ma'am.
Thank you. Sorry for the technical glitch.